So welcome back. I hope you all had some nice food and you managed to grab a cup of coffee as well. The second half of today is continuing. We have with us Mr. Leon DOORN. He's the co-founder and CEO of MedQAIR. I hope I pronounced this correctly. And he will tell us about the AI Act and how this influences the businesses we do. So please, the stage is yours.
Yes. Yeah, you can hear me now, right? So first of all, thank you for the welcome. And thank you for the great morning session as well. And I'm going to be honest with you, probably my session is going to be a little bit more in depth and is going to be potentially a little bit more boring because we're going to dive into the regulation and see how the regulation actually affects manufacturers within the field of medical devices, but also the healthcare organizations themselves. So the AI Act and the implications of the AI Act on the medical device industry. And maybe it's good to mention for a few seconds that I've been working in the medical device industry now for nearly 17 years. Over the last 7 years before I started my own company, I worked for a company called Aidence. Aidence was one of the first companies in this space that actually developed an AI solution to detect and classify abnormalities on lung CT scans. And we were quite an early adopter of artificial intelligence as a technique. And since then, I've been responsible for quality and regulatory affairs within the organization. And from that role, I also transitioned more towards standardization. And that's what I'm still doing today as well. So I'm helping writing actual medical device standards, but also standards around artificial intelligence within JC21, but also in SC42. And at the same time, also a little bit involved in the standard writing of TC62. So I do understand a little bit of the implications on that end. In JDC21, who are developing the standard for the European Union, the European Commission has been very present. Also when the AI Act was still under development, so they also provided some communication and early insights in the ideas and the thoughts behind the AI Act. So if anyone's interested in a little bit more of that background, feel free to ask. So a little bit of the timeline, right? We saw that in April 2021, the first version of the AI Act was published, and it's undergone quite tremendous changes. For anyone who's not aware with the AI Act or how it's being set up, it's a horizontal legislation. That means that the legislation itself doesn't just cover the medical device or the healthcare industry, it covers a lot of industries. So it's a lot broader than just healthcare. And one of the things that was missing from the AI Act when they started building it is that we've seen over the last years, and probably we will see a lot more developments around artificial intelligence. And one of the main things that was missed when it was initially written is obviously the rise of LLMs and the use of systems like ChatGPT, but also Copilot and other systems that truly alter the way that we work in our everyday lives and alter the way that we look at, it just has a very big opportunity to transform our societies. And that led to a major development and rewrite of the AI Act, which was done in 2002, which introduced the use of general purpose AI systems. I'd like to believe that the way you read it is that they decided on the whole legislative framework and then thought we need to push in also general purpose AI. We'll just add it on top and we'll combine it. And that created a little bit of a weird structure of the AI Act itself. So that these two items are separated, but that is what it is. And we'll see how this will develop over the coming years when new technology starts coming out. The AI Act was adopted in May 2024, and then the publication in the official journal was in July 2024, and that meant that it came into force already in August 2024. So we already passed the first year of the AI Act being in force, and already with that, gradually, a number of requirements start becoming applicable to organizations. One of those, for example, is the AI literacy requirements for people who are unaware. That means that organizations, any organization, I'm not talking about healthcare specifically, that uses structurally AI systems within their organizations should ensure that the staff members within their organizations are trained to use the artificial intelligence systems and understand what the risks are involved with the use of AI. It's a requirement that applies to all organizations. On top, there are prohibitions entered into effect in May 2025. So if there's forbidden AI systems, they're no longer allowed to be on the market today. And you see that the general purpose AI models, the new ones that are now being brought onto the market since last August, already need to comply with the legislation. And on top of that, there's an ultimate date for the post-market surveillance plan, or post-market monitoring plan, is what it's called. That will be coming out before August 2026. And also the application of the high-risk AI systems that are called out in Annex 3. And then 1 year later, exactly, that's August 2027, we'll see that the legislation will also apply to medical devices that are being brought onto the market. So all the medical devices that are on the market today that embed AI should be compliant by that date. AI literacy, I just wanted to call it out. I already mentioned it very briefly. So it's a requirement that doesn't just apply to medical device manufacturers, it applies to hospitals, it applies to any organization using AI systems. And that means that the staff and other persons dealing with the operation and the use of AI systems, taking into account their technical knowledge, expertise, education, training, and the context of AI systems are to be used in considering the persons or groups of persons to whom the AI systems are to be used. So that means that people need to be AI literate. I'm not sure how many here have already provided training to the staff members or have assessed whether they're actually using AI systems. If not, then I suggest that a good moment to do that is now, because you're probably already required to be compliant. Then I'd like to call out two specific roles within the AI Act that are crucial. And the first role is the role of the AI provider. And you might know the AI in the field of medical devices, we always talk about the manufacturer. In the field of AI, the role of the manufacturer is being called a provider. It's not one-on-one synonymous. That doesn't mean that all the providers are necessarily manufacturers and manufacturers are necessarily providers. But in the case of medical devices, that means that if there's a medical device and it includes artificial intelligence, that the manufacturer is also a provider of an AI system. And yeah, it can apply to a very, very broad range of people, of organizations. The other role is slightly more interesting, which is the role of the deployer. So when an AI system is being developed, it's being provided to be used in clinical practice, for example, then the party who actually purchases the AI system and starts using it in the field is the party that's being called the deployer. And there's specific requirements in the Act that apply to the deployer and not necessarily solely to the provider. So if you look at the medical device regulation we have in place today, the requirements apply to the manufacturer. There's no requirements for healthcare institutions in the medical device regulation. This is different in the AI Act. So it also puts out very specific requirements for the deployer. And it gets interesting when you read what it actually says. It says, and I'll point it out, the deployer means a natural or legal person, public authority, or another body using an AI system under its authority, except where the AI system is used in the course of a personal, non-professional activity. And they explicitly state a natural person here as well. So in the event that you have a physician working in a hospital and the physician decides on his own to use an AI system in his work, so for example, he uses ChatGPT on a daily basis to summarize some patient data, which they probably shouldn't from GDPR constraints, but just as an example, where he uses another system on his own personal level, that means that they probably qualify as a deployer and they have to comply with certain requirements out of the AI Act. I don't think people are really aware of that. And the other one is the healthcare institutions purchasing and implementing AI systems. So those are just the healthcare institutions that I just called out there will be considered the deployers. So a little bit about risk classification. And I would like to state that this is an under-representation of what the Act actually does. So if you look at artificial intelligence systems, you have different types of artificial intelligence systems that are described within the law. If you try to look up what the classification systems are, you'll find that they're broadly talking about 2 or 3 risk classifications. But to my personal opinion, there are more, and there's even more than what I've written down here. So you have prohibited systems, so AI systems that are no longer allowed to be on the market. They also talk about high-risk AI systems from Article 6, where, for example, systems that can prioritize urgent healthcare, which would be called out in Annex 3. Annex 3 is not the same as Annex 1 high-risk systems. There's differences there already in their classification and how they're being brought to the market. All medical devices fall within Annex 1. So that includes medical devices, but also in vitro diagnostic devices. And then continuing, you also have general purpose AI models, which are non-systemic risk. You have AI models that are systemic risk. And then there's also just all the other AI systems that introduce little to no risk, but to which some basic requirements might still apply. So you see that this is already quite a bit of a classification, but then even in Annex 1, there's a list A and list B, where list B, for example, again, has different requirements that apply than the ones in list A. So it's just complex. For healthcare organizations, there's a number of changes. So this is more what the requirements are that will apply to the deployer, right? So this would also apply if you're a doctor and you're working in a hospital and you are deploying an AI system. That means that these organizations need to implement, and I think this is not entirely clear yet, but technical and organizational measures, a term that we know also from ISO 27001 and from GDPR. What those technical and organizational measures mean is yet not really defined, so something to be monitoring. But I would state that these measures need to ensure that AI is being used in line with the instructions set out by the AI provider. So if the AI provider says the AI system must be used in a specific workflow, in a specific way, the data that's being fed into the system must be X, Y, Z, that means that a healthcare institution who deploys the AI system needs to make sure that they comply with those requirements, and they need to have, demonstrably, technical and organizational measures in place. They must assign the right level of human oversight. So if the manufacturer states, the provider states, every output of the AI system should be verified by an individual, then that's what the hospital must execute. That's very simple. Also select, inform and train the staff members. Already noted, right? The people that are using the AI system must be literate. So that means that the organizations, the deployers must have proper training programs in place to make sure that the people are trained. And for those systems that are called out in Annex 3, some of you might be familiar with the data protection impact assessment, which is done in line with the GDPR to assess what the risks are to the rights and freedoms of individuals. The AI Act does something similar and says you need to do a fundamental rights impact assessment. So if I'm starting to use an AI system, and again, from Annex 3, something that could prioritize healthcare, for example, you need to make sure that you've assessed what the risks are to the specific persons who are subject to the AI system. And then there's also another technical items that must be met. So ensure relevant and representative data input. So all the data that's going into the AI system to generate an output must conform with the requirements that are specified by the provider. You must monitor the operation of the AI system to make sure that there's no strange outputs, or that if you're detecting something that's potentially off, you go back to the provider and inform the provider that something is wrong with the AI system. And then store the automatically generated logs for at least a period of 6 months, which is also quite interesting, I would say, because that means that organizations will actually need to start monitoring this. Going to the next slide, and this is a little bit more detailed on the manufacturer side. I'll try to run through it because I think we don't have a lot of time left. So there's 3 main pillars, I would say, and I'll just call out what the biggest ones are. So you have quality management, technical documentation, and conformity assessment. A lot of these items are very much aligned with what is required for medical device manufacturers today, but then there's also a lot of differences. So if you go into a little bit more depth, you'll see, for example, that for risk assessment, manufacturers should address fundamental rights risks, and they should address data management, and also in technical documentation, right? It means the detailed AI descriptions, for example, but again, also the fundamental rights risk assessment. And I think this one, the fundamental rights that comes back to the whole AI Act, is still one thing that's entirely new, and it leaves a lot of discussion open. Also in the standardization community, they're trying to put out standards that will help you to address fundamental rights risks, but there is a lot of debate, and it's still very much unclear of how you can achieve this. So we'll hope to see guidance, or at least support in the next coming years. And then the last part on the conformity assessment, one interesting note is that the AI Act doesn't just demand that providers declare conformity with the AI Act, but also with the GDPR, which is interesting. And then access to data sets for notified bodies. So manufacturers that train their AI system using data, they must provide that data to the notified body if requested. And notified bodies might actually choose to retest the AI system if they want to. So a number of challenges overall with the AI Act that are still to be resolved, in my view, is the timeline, right? So 1 year has passed, there's 2 years still pending. And to date, we're still not having accredited, notified bodies. So without notified bodies, manufacturers still required to go to an agency to get that certificate updated against the AI Act, and we've seen this with the MDR transition from the old to the new legislative framework. That's still not finished, right? So a lot of devices are still not compliant with the new MDR. So I'm truly interested to see whether 2 years is going to be an achievable target. Standards are running behind. I've seen a recent update, I think it was published a month ago, that some of the standards are delayed almost into 2027, whereas organizations need to be compliant in 2027. So if there's no standards, how do you become compliant? It's a sort of a problem as well. No grandfathering, so that means that if something is approved today already by a notified body, it doesn't mean that you can just keep it on the market after that compliance date. So if it doesn't comply in 2027, it needs to be taken off the market, unless there will be a transition document or guidance that will state otherwise. Again, limited guidance documentation to date, and I think the last point is what also will touch a little bit on the next discussion topic, and it's the availability of data. So the AI Act raises the bar in the requirements to data, and that means that if you have insufficient data today and it doesn't comply with the requirements of the AI Act, you might need to get a new data. But data availability is a truly big problem for AI systems. There's just a lack of data. For my company that I worked with for 7 years, all our data came out of the US. We had 0 patients from the EU. Why is that? Because the data is just not available. Hospitals are not willing to share. There's very difficult ways of being able to capture the data in the European Union. And hopefully, the EHDS that is going to provide rules and guidelines for making data available for secondary use. I hope that's going to unlock the data that is so much needed by these organizations to train and test their AI algorithms. I'll leave it there. This is the end of the slide deck, and I hope that gives a good bridge to the EHDS panel.
Thank you so much, Leon. Yes, I think you can already grab a seat. I will take this just in case. And now I'm really glad and happy to invite on stage Elina DRAKVIK. So she's been really fantastic in doing collaboration with us over the years, and the great work she's doing in Sitra with TEHIK is really inspired. So I'm really happy to give the floor to you now to moderate the session. And this is also a clicker here.
Actually, I won't need the clicker, but thank you for the introduction, Sven, and thank you very much for inviting me. So I'm leading TEHIK joint action. It was already mentioned a couple of times by Melody in her keynote speech, and then also by Michel. For those of you who are not familiar with TEHIK, so TEHIK is a joint action that is really helping with the practical implementation of the European health data space. So we are providing guidance documents and technical specifications for the health data access bodies, but also for health data users and health data holders, so that they know the implications of the European health data space regulation. And we are also trying to harmonize the practical implementation across the different member states in Europe. You know that we have a bit of a challenge because there are some, let's say, different kind of maturity levels in the member states. When we talked, for example, this morning about the digitalization and the healthcare systems also. So we know that we have a challenge, but we also have very strict timelines, and the regulation has already entered into force, so we know what we also need to do. But I want to draw your attention to a couple of key points. As Melody was saying, There will be public consultation for the implementing acts, but more so, public consultation for the TEHDAS2 documents. So all the technical specifications and guidelines that we will be producing in TEHDAS2, they will be put up for the public consultation, and the next public consultation is opening up at the end of September. It will be open for 2 months. It will be a long list of documents, so we will be having more or less 10 documents for you to read and comment on, provide your input, feedback. We want to hear from you. We want you to be involved in shaping the future of the European health data space. So please be aware, stay tuned, follow our website and LinkedIn. So tehdas.eu is the website where you will find those documents then. I will just provide a couple of examples what kind of documents that you will be finding there. So for example, guidelines on fees and penalties, but also guidelines regarding the pseudonymization and anonymization and synthetic data, and also technical specifications for the IT infrastructure, but also technical specifications how the secure processing environments will look like, and the sort of the criteria demands for those. There will be also guidelines for the health data access bodies, how to deal with the clinically significant findings from the secondary use of health data, but also then how to implement the opt-out mechanism. So lots to read and comment on. But now, without further ado, I will introduce the panel. So we will continue deep diving into the EHDS. The title is, interestingly, Still a Dream or Reality? We have talked about dreaming today, so we can still continue the discussion. So let me introduce you our distinguished panelists. We have Jaanika, MERILO, Head of Health and Care from the Estonian Ministry of Social Affairs. We have also Michel SILVESTRI joining us, Head of Unit. Well, you know, Michel was already in the first panel, but we love to continue the discussion with you. We have DOORN. Thank you for the excellent keynote speech. It was really interesting, and we will also touch on some of the topics that you brought out in your talk. And we have Rutt LINDSTRÖM, data standardization expert, TEHIK. Welcome. And last but not least, Lenne-Triin, KØRGVEE, sorry about the pronunciation, director from the Tartu University Hospital. So thank you very much. We will start with the member states perspective because we left there. The discussion time ended a little bit. So I will look at you, Jaanika. We heard about the national level developments more generally in terms of digital health in Estonia, but now more deep diving into the EHDS. How the progress looks from your perspective. What is happening in Estonia specific to EHDS? What are the next steps? And how would you compare the situation relative to other countries to Europe?
Yes, hello everyone. Some of you saw yesterday already in our fireside chat, but I had a really nice day and actually so many ideas. But in regards to practical implementations, let's not dream, but let's plan. Two different things probably, yes. In the national level, we're quite well already corresponding to most of the 2029 requirements, meaning that of course we have lots of implementing acts coming in regards to interoperability and requirements to EHRs, certain standardizations, we have to set up the age gap, certain things more, but in regards to big topics, cross-border data exchange, prescriptions, patient summaries, we're doing quite good. And actually, yes, as it was mentioned, I cannot see my Finnish colleagues, but we already launched cross-border data exchange in regards to e-prescriptions in 2019, and it's been really rewarding, meaning that we can really feel the difference or see we have over 40,000 of e-prescriptions exchanged with Finland. Latvia and Lithuania joined this last year, the cross-border exchange, and we can feel the impact, meaning that it's like very in demand. So we're already preparing for the next categories in regards to cross-border exchange in primary data, the medical images, and we plan to have them ready for cross-border exchange in 2 years. So we kind of understand what we will be doing by 2029, meaning the small things, the biggest things. We will be working a lot with implementing acts. And I'm actually very happy that we have set up a quite well-functioning eHealth strategy board, which means that we have 20 different stakeholders, IT associations, doctor associations, universities, and so on, whom we gather regularly and with whom we share also these consultation documents. And this collaboration is working quite well, meaning that we really do get the feedback, the input, and we have this small network to spread out the documents and get the so valuable feedback. Again, we're rather looking forward to 2031 plus in regards to secondary data exchange, because in regards to primary, it's already quite much there, but the secondary will really open up the new perspectives, especially in regards to pooling together the secondary data with other countries. We're starting to pilot with Finland, pooling data together, because there we can see that it brings so much value to research. And so I would say Estonia is doing quite well in regards to timeline, but we do understand that it will really have the full impact if all the countries will be there. Meaning it's not a standalone project. We cannot do again in silos, meaning countries being separate silos. That once it will be rolled out in all EU countries, and not only as a checkbox that yes, we have launched it, but really rolled out, we will then feel the impact in regards to primary and secondary. Because if Estonia exchanges with Finland, it's great, but that's not the meaning of EHDS. So when we will start pooling data together with, I don't know, Germany, Austria, whatever other European country in regards to providing better data, better structured data, better standardized data for research, and it will be smooth and the processes will run smoothly cross-border, then we will achieve the goal.
Excellent, thank you very much. And also very happy to hear about the pilot studies with Finland on the secondary.
It's a little bit secret, right?
Yes, so we're very happy to hear that. But let's continue on the member state side and also from the news from Sweden. So what is happening in terms of the progress in Sweden concretely on the EHDS, and also what do you see as the top priorities to make the EHDS a reality? Michel.
Thank you, Elina, and again, thank you for the invitation. Well, I mentioned a little bit during the morning session with the supporting slides as well. I think that to start with, we have an ongoing government investigation or inquiry, maybe you call it, led by a guy, Mats Nilsson, who looks into the details of the preparations for EHDS, estimation of costs, proposal for distribution of responsibilities when it comes to HDAB functions, etc. HDAB is the Health Data Access Body, or bodies, maybe in plural. So I think, for instance, we need clarity when it comes to that distribution of responsibility between the different Swedish authorities and agencies. And at this point, according to this investigation, the government seems to move in a direction that the role as coordinating HDAB will lie under the National Board of Health and Welfare. Socialstyrelsen is the Swedish word for that, but also in combination with a responsibility for the secure processing environments, probably lying under Statistics Sweden, for instance. And then also supervision lies under an additional existing agencies. So the HDAB functions will probably be distributed between these different agencies and authorities. To be honest, a little bit disappointing for myself and maybe for my agency, the Swedish eHealth agency, because we've been the competent authority in all the preparating EU projects, and also we're leading the Swedish part of the VALO project that has been mentioned earlier, the Nordic project, or Nordic-Baltic, I would say. But we will probably have a main responsibility in my agency when it comes to primary use of healthcare. And again, we've talked a lot during the morning session and also during lunch about the importance of actually having primary use and secondary use integrated as much as possible. So we must have that in focus all the time. Just in addition, and to conclude this part from my side, is that we have ongoing government assignments, especially within my agency. I led, for instance, the first part of presenting a roadmap for a national digital infrastructure in the healthcare sector, or for health data. And that is ongoing with follow-up assignments. And now we're actually starting to building parts of this national digital infrastructure that will be, as I mentioned in the morning, truly national, a little bit in contrary to what we have today, which is a distribution of different infrastructure subparts in a way. But again, this national infrastructure, of course, needs to be compatible and aligned with the requirements from EHDS. And again, we still are waiting for the implementing acts to provide us with the details that we have to comply to. So I was thrilled to hear about, for instance, the upcoming drafts or deliverables from TERAS 2 when it comes to secondary use. I'll stop there. Thank you.
Excellent.
Our draft for extended EHR. I thought you would do that, Rutt, because you're really a key person in that part with extended EHR for primary use.
So if you can't wait for the secondary use stakeholder consultation, then the primary use consultations are ongoing right now, and we are waiting for everyone's feedback.
Excellent, thank you very much. And I just want to comment, Michel, this news from Sweden, because it was new to me that this sort of delegated responsibility, it's more diffused, at least how it seems now. So thank you for sharing the news from Sweden.
It's not decided fully yet.
No,
we clearly see the direction from the government.
the development.
And of course, we all Swedish agencies in this case collaborate, so that will be no problems.
Okay, right. Rutt, yes. Can't wait to hear your comments and views now on EHDS, but you are more from the standardization perspective. So we of course know that the standards are key for the interoperability, but how exactly do you see the path for developing and implementing that in the EHDS?
So yes, so I have two perspectives. I work for the eHealth agency in Estonia, TEHIK, but I also work as a hobby job for HL7 Europe, which is the standards organization. And the perspectives, luckily for us, are not that different, or luckily for me, I don't have to wear hats and speak completely different things. But I don't think we're that united in Europe in regards of standards. So I think everybody agrees that it's a good idea to use standards. Like, we don't have any problems there. The problem is when we come to choosing standards. So which standards are the ones we use? So we see, okay, there are 10 standards that are doing something like we want. They all have their problems. You know, this is good for this thing, this is good for the other thing. So guess what? Let's make our own. Because, you know, I think we can do better. And that happens a lot. So luckily for EHDS, for data exchange, for primary use, we managed quite early to decide that we will use HL7 FHIR. So at least we know the main standards that we are using. We are not agreeing on the version of the standard, and there are also various ways to implement one standard. And also, like everything else around it is also like it's a tug of war. So somebody is dragging the standards work this way, some other countries that way. So it's not so clear. But what we gain from the standards, I think that is clear, especially when we are implementing HL7, which is like a global standards, especially for app makers or EHR vendors. They actually want to use their product not only in EU, but they want to go to other markets. So using global standards will make that much more easier for them.
Exactly, and also bearing in mind the third country access in the EHDS then in 10 years timeline from the entering into force. So we also need to think about into the future and the bigger picture, not only European perspective.
Yeah, and I do encourage us to think of this in a bigger or like longer perspective. All the European projects right now are sort of about advocating or sort of marketing for seamless data exchange. So I don't think we are in for a seamless data exchange for the near decade. So we are really quite robustly patching things up, trying to make sew it together. And if the seams hold, we don't care if they're very scratchy, but at least they hold. And I think that's already good progress. So we shouldn't think of it like in 2 years' time, we have EHDS, all the problems solved, and then we're in for a disappointment. Like, guess what? We still have problems. But yeah, we just need to have this longer perspective.
Exactly, exactly. And practical views as well. Keeping feet in the ground, even though still counting on the vision, so to say. But let's move on to our next panelist. So, Leon, you already mentioned some of the challenges with the AI Act. So, speaking more from the regulation side and the different regulations and their interaction, you also have the consultancy and work a lot with the companies and industry. So, what do you see are the sort of challenges at the moment, and how EHDS could also bring some of the solutions to the table at some point?
Or maybe start with the challenging side instead of the solutions. I think if you look at a general startup right now in the medical devices space, and one that makes use of artificial intelligence, and you can think about, you see the rise of LLMs as well in use of medical devices. And also that digital medical devices are becoming, especially the software as a medical device, are becoming bigger, and they're not just only having medical device functionality. So some of them will have medical device function. There will be other parts of that medical device that might not fit in there. And one of the challenges, I think, is that with the multitude of legislation is that for some aspects you need to look at the medical device regulation. For some aspects, you will need to look at the EHDS, because the other modules might be classified as an EHR system under the EHDS. And that's only 2 of the legislations. Then we have GDPR, and on top of that, there will be the AI Act. And then on top of that, you have the Data Act. And I think that for small organizations that just make a small medical device, a small SAMD, that consists of both artificial intelligence and a medical device, and potentially an EHR system, this is just becoming a very complicated environment to work in. Understanding the whole framework, and that I think is the challenging part. And I just mentioned it in my presentation. I think one of the biggest problems, structural problems in the European Union for AI organizations and medical device startups that need that data to train their algorithms, it's simply not available. The structure today is not there to get data from hospitals, and I think that is where hopefully the EHDS will provide a crucial part in unlocking a lot of data for training and testing of AI algorithms. Although I recognize there are still challenges within the EHDS that might make it complex. So if a medical device manufacturer would need specific scans or scan data, image data that could re-identify a patient, would it then be possible to get that data because it's not anonymizable? Well, these are the kind of challenges that continue to exist.
Thank you. It seems that you will have a lot of work also in the future, or the industry coming up, because of the kind of, some say even a legal limbo, but we also know that it's the regulations, once they are in force and there's more sort of guidance documents available, they will also bring more stability and predictability then. But definitely, yeah, these are challenges that are recognized very much. Now we continue then towards the solutions after a while, but before that, we continue with the hospital perspective. So now I'm looking at you, Lenne-Triin, and what are your expectations from the EHDS, and how do you see also the challenges?
Well, first of all, it seems that we have heard that a lot of wonderful work has been done so far, and the framework is there. But it seems that I'm here today to take the message or represent the real world point of view of the healthcare provider. And maybe it's wise to remember that this is the place where most of the, at least disease-related data is being created. And we struggle a lot, actually, with very many things, and it seems that we have such obstacles and challenges that can eventually hinder also our common shared dream to have that nicely structured with high quality data European health data space. So we have huge hopes for this. So I can come later on back with our struggles, but going to your question, considering or representing now the point of view of a doctor dealing with rare diseases and ultra-rare diseases from a small member state, I think the first and the most urgent need is to have quick and reliable access to, for example, second opinion systems. So, example from the last summer, I had 3 infants in intensive care, and one of them, we got the diagnosis, and that was the first diagnosis of the kind in Estonia. So, and 2 of them, we didn't even get a good diagnosis, and one of them, pathologist, provided us 12 diagnoses that the disease was not, and how can we treat? So I initiated pan-European like search for help, for the pathology, for the clinical, for the management, and it was not. And this is the way the world now is. In full detail, I believe GDPR compliant. Of course, the patients and the parents are consented for all of this. But I see European health data space to provide quickly, timely, reliable, secure access for such situations. Also, if I refer patients to abroad centers, for example, one of these patients ended up in proton therapy in Sweden, and we have to exchange clinical data a lot. And I see this cross-border exchange through this European health data space of enormous input, because again, we share the data, but it's not maybe like it should be. So for the patients who come here, I would love to see quickly, reliably the diagnosis, the treatment that has been performed, allergies, simple things. So from the manager point of view, or somebody who is responsible for quality, I would love to benchmark the outcomes. So to compare the outcomes of the treatments we provide here to address any problem areas as early as possible, and for the regulators to provide data to base their decisions upon, and for a researcher point of view, this is enormous opportunity to use all these data. So from a clinical point of view, we dream that we will all together manage, but we have to work hard and we have to focus. And I believe, to give the focus here now today on also the healthcare provider perspective, because things there are not so brilliant as they seem to be in the following levels. And maybe, well, it's also wise to keep in mind that you don't have any better data than we do. So if we don't have a good data, then the national level doesn't have good data, then the international level doesn't have good data. So we have to turn our focus a bit on this healthcare providers also within this large framework that's already there to be able to provide all these things that we would love to have all together.
Thank you very much. And actually, I want to come back to this discussion a little bit. What part of you had already this morning, this interlinkages between the primary use and the secondary use, and what you were also saying about the hospital's role. We heard from the morning discussion that yes, EHDS, it's a regulation, so it's an obligation, but how do you sell this obligation and the data quality aspect and the whole data culture thinking in a hospital environment, especially concerning the secondary use of health data? So what could be like concrete steps forward? We know also based on the experiences in Finland and the TEHDAS 1 sort of mapping we did, that the healthcare professionals don't always understand the value of the input data that will be then later on used in the secondary use. So how can we make this link better?
So the question is about the secondary use mainly. I usually start, if I have a new lawyer or data officer in my group, I start very simple questions. This is mostly about communication. What do you think is the 5-year survival rate of adult cancer patients? Do you know? Do you know what would be the 5-year survival rate of adult cancer patients? Anyone? Something. So are you happy with it? Do you think it's satisfactory? No. So what should we do to change it? What should we do? What has brought us so far is research, and only research is something that will bring us forward. So we have to do and boost and do everything to support these people who are willing to do research. And if you are going to integrate regulations and GDPR, please keep that in mind. Don't be too strict. Try to find the ways how we can do, not try to find the ways why we can't do. And this is for our professionals. And this is, I think, we need to communicate for the society also. This is our task for them to agree what we do here, to use their data for research, to make things better, so that not only 5 to 6 people out of 10 will be alive with cancer diagnosis after 5 years, but maybe it will be 8, maybe it will be 9 at some point, and we need to do research. This is communication within the hospital, this is communication outside to the hospital, and this is how I have been approaching. Of course, the society, this is something we need a lot of help from you, from everybody, because this is not our primary task to make this work, but we are trying as much as we can, because our primary task is to treat these patients. So, and of course, as a university hospital, of course, we want to do research and provide all means for our researchers, which is another story and a problem also.
Excellent, thank you. Yes, please jump in.
It's just a small thing to add, right? Is what you mentioned, and I fully recognize it. But for the secondary use of the data, you mentioned research, and I agree on the topic of research clearly. But it's also the making available to commercial companies who actually turn the product out of that data and bring it onto the market.
So if it's fair, if it's clear, if the burden is equally distributed, we must do it. Together we can move faster. There's no question about that. Yep.
Excellent. And now, Jaanika, your take on this.
Yes. Well, I want to resonate, meaning that for last year, we created eHealth strategy, which means we really engaged all the stakeholders we could, from the doctor's perspective, nurses, hospitals, and so on. And for from whatever perspective we asked, what is your main priority, what is the main pain point or issue, everyone pointed out data. Meaning doctors need high quality data for better treatment, for better basically research. Companies need better data for creating better products, for modeling AI. Policymakers need data to make fact-based decisions and so on. So from each and every angle, it was about data. And so we have eHealth strategy in place. Now we're working on implementing a roadmap. And we have approximately 20 points in regards to data, meaning the data quality. Yes, we have lots of data. For 25 years or so, we have gathered data. But I don't think there is any country that could say we have high quality data, all standardized, all like perfect. No, and we very much understand that. And this is why our new eHealth strategy is basically the cornerstone is data, meaning how to make it standardized, available, fastly available for secondary use in regards to different use cases, policymakers, doctors, definitely, what standards to use, how to start from the grassroots in the good way, so that the healthcare professionals know how to input, why they need to input, up to the highest political level that you make facts-based decisions. So just wanted to underline that we completely share this understanding that the high-quality data is basically the pillar of everything else. You cannot build anything or model AI, garbage in, garbage out, meaning you will not have good solutions, decisions, policy making if you don't have high-quality data.
I'm really happy to hear that.
Yes,
and
maybe Michel, maybe a bit provocative question to you, but I know you can take it. Now we have talked about the importance of high quality data, and some would argue that the EHDS itself doesn't make the data quality improve directly. How do you see the issue?
Well, I think you're right. And again, I don't know exactly right now to what extent that will be handled in the implementing acts or the deliverables prior to the implementing acts. But I hope there will be. I mean, EHDS still discusses this data quality utility model or something like that. Again, we had this interesting discussion during lunch, you, me, and some colleagues here, that when we're talking about primary use and secondary use of health data, it's very much the same data, actually. Yeah. And that's very important to understand. And that's also one reason for me not using the terms primary data and secondary data, because then it gets a bit confusing. So primary use and secondary use is my preference, and according to the EHDS regulation. So of course we need some kind of model and driver for improved data quality within or from the EHDS. And both for primary use, according to the standards, for instance, that you work on, Rutt, and also, of course, the preparation of the clinical data for also reuse and secondary use for research and other purposes. And we've seen, for instance, in the VALO project on a Nordic level, that we have this standard OMOP, or OMOP Common Data Model, that is maybe known to several of you in here. That is one such standard, you can call it, for preparing clinical data for research. And it was painfully clear, for instance, for me as a Swede in the VALO project, that the Swedish OMOP maturity, if you would call it that, was not at the same level at the one in Finland, for instance. So in that case also, I think this collaboration and these efforts, and when we get together solving all the challenges for EHDS, that is also stimulating and in a way benchmarking, and you don't have to invent the wheel by yourself every time. So instead we can go together and solve it. So it's important, data quality for different purposes, and I think that EHDS, the way we're working now, is moving us in the right direction, hopefully, more or less.
Yes, good points. Now let's continue on that topic, but now I would like to ask all of you to think about more sort of concrete measures, how to overcome these silos. I mean, you partially already answered, Michel, but now let's continue with Rutt and your perspectives on the standardization especially, and what kind of can we do together to overcome these silos from the primary and secondary use side?
Oh, if I only knew.
Difficult.
That's a small one. Yeah?
That's a small one. I think we have people who would be interested in working in both and you know, break the silos. The problem is really the resources. So from what I see in European working groups, we don't have enough people who would be able to do this interdisciplinary work. Because most of them are in those working groups as side jobs. So they actually have a full-time job in their own agencies, and then they are sent to all sorts of projects and working groups to do something there. But that's sort of like something you do at night then, or weekends. So we're really, I would say it's not like we don't want to understand each other. It's really the resources that we are struggling with. I don't think this was from a standardization organization's point of view, but that was more from the national agency's point of view.
Yeah. Michel?
And just to add to that, and because we often get back to that, the lack of resources. And it's not only money,
it's not money
or investments, it's actually competence, human resources very much, and also time to some extent at least. I mean, we have relatively short time to fulfill all the requirements and all the ambitions in EHDS.
I can add a little bit from a standards organization's point of view, actually. So in EU project, yes, when we have these national organizations there, national agencies, and we struggle with finding time. So what we have been able to do through engaging with the standardization organization is to engage their communities and then vendors and other people, other stakeholders who would not otherwise have access to these projects. Then through these standardization organizations, they can actually contribute, and they have contributed a lot. And I think it's been very good for EHDS to be able to do that. Yeah.
You have to engage the entire ecosystem, right?
Yes. Leon, you want to...
Yeah, just one small comment on this is that, and it's not entirely the same, I realize that, but to the standards point, right? What I see in the standardization around artificial intelligence and the AI Act is also the problems you run into. One is that some standards are heavily overrepresented. There's a lot of people that have interest in a risk management standard, but then more of the technical standards, there's just hardly anyone there available with the right expertise or the time to work on it. And that is problematic. So where you see a risk management standard, where there's high stakes for a lot of organizations from various backgrounds, the standard that got proposed received 350 pages of comments, whereas the standard itself was not even 50 pages, just to give you an idea. So that makes it really hard to get to a consensus and to provide standards. Whereas on other standards, there's just no one there. There's a concept of a standard, but no people to prepare it. And if you have one person to write a standard, then you don't get a good quality standard. So that is, the resources are definitely also, and I think it's a shared problem across EHDS, medical devices, Artificial Intelligence Act. It's all fishing in the same pool of people. Absolutely.
Your take?
Yes, if I continue with this standardization, so I believe in some areas it's a bit more advanced already, but if you're talking about clinical terminology standardization, and really hospitals, it has been also quite a challenge, and we have just recently managed to agree upon in Estonia with our colleagues from Tallinn also upon 40 essential cancer data items, so that we agree that this is the date of diagnosis. So it's not earlier, it's not later. This is the time point, because it's not possible to compare, because if we define them differently. So the standardization is one really obstacle, and really to bring all these personnel together, to find the common ground to all highly skilled specialists who everybody has their mind of their own and the idea of their own to agree upon something. So within Estonia, and in cancer care, we have started the process. We have done 40. I think this is a lot. This is good, but this is just the beginning. So we have to move on. And now coming to your first question. So it can be done, but you need to put a lot of effort on it. And if we widen the area, not Estonia, so it becomes more complicated. But I think it can be done, because if I understand why we are doing it. But the silos, I think the silos, this is one of the problems within the hospital with the data. For example, in our center, and I know also it's the same situation in other centers in Estonia, we have information, data lies at least in 6 different systems. So it's the pathology module, it's the system therapy, it's the radiotherapy, it's laboratory, it's genetics, it's electronic health system. The systems do not talk to each other, they don't change, they don't integrate. So if I, as a clinician, want a quick overview of what has happened, really the basic things with my patient, I have to look from here and there, and this is not the situation that it should be. So we have, if the question was how to overcome. So at one point we were sitting there and thought, we have now addressed the problem, so what should we do? And we decided to apply 2 approaches. One of them was indeed OMOP. So to my understanding, we are the only hospital in Estonia who is building now the OMOP, but it's not funded by Estonia or our usual funder. It's European money, and it's a project. And we are building this OMOP with 21 cancer centers in Europe. But the question already now for me is, what happens if the project is over? So we would have this really nice standardized data set, but how about the sustainability? This is one route we have now decided to go on, and we still haven't figured out about the sustainability problem, but we need to focus on it. But we are building it, and the data is already going into OMOP. And the second is, together with our colleagues from also Tallinn, to how should I say it in English? It's like a national cancer module within TEHIK. And now I'm a doctor. I have learned some words, back end, micro level, granular data exchange, so that we change our habits or culture of data capture from the grassroots level. There are no extra secretaries, there are no extra duplications or steps in between. It right away goes to the right place, and so we can use it, and it right away goes to this national, whatever it is going to be, core. So it can be used by other colleagues from Tallinn, from cancer registry, from the policymakers, from the regulators. So the initiative is already there to also change, to overcome the silos, and so all this, the data that lies in different places, and of course some of them is structured, some is this free text, we have the standardization problems. So we have to approach it multi-level altogether, but should go into this core data sets, so maybe eventually from there also this European health data space. So we'll see. We have started, we don't know where it ends up, actually.
Thank you. I like this positive attitude, and we can do it, yes. Now we have time for questions from the audience. If we have any questions, yes, we do.
Thank you for the brilliant panel. Thank you so much. I want to play a little bit different role, and I want you to maybe try to see it from the different angle. So 2 points, maybe, and I will try to be short. So I think that we have to look at it from a little bit different angle, because let's say all the people who are very spiritual, they are saying that all the conflicts in the world is just because of the one thing, because of somebody don't know who he is, right? And if we all know who we are, then we shouldn't have any conflicts. But why I'm referring to that? Doctor, you are still a doctor. You don't have to think about OMAP, you don't have to think about data standardization, about backend, about servers, about anything. You are a doctor. You have to do your own thing, your own research, and the other people, those who are paid for that, should think about this. And I think that in Baltics, less maybe in Nordics, but in Baltics we have very, let's say, a crucial problem. We want to do everything on our own. We are still, you know, we are living in this old paradigm that we are fixing things and building things on our own. I wanted to build a garage, and I understood that I'm not a builder. So I better pay somebody who is doing that. Yes, it's going to take some money out of my pocket, but the end result will be more with higher quality. I would urge everybody to think about really about that. Concerning governments, we are here Latvians, Lithuanians, Estonians, and from Nordics. Lithuanians are, I think, like top one. They want to build everything on their own. And that's fantastic, guys. But maybe let's not do it. Latvians are actually the same. We also want to build our own systems, our own environments, and so on. There are some rules and some borders, or some red lines, which we shouldn't go over to. But the last point is that the problem is that we are not speaking with each other. We still live in the silo that healthcare is a healthcare, but we have to understand that healthcare is also need to be approached as a business, first of all. Because if hospital won't operate as well as a business, it will go bankrupt, right? And business always take care, if they don't know something, they ask an opinion. And that's the crucial problem. Not our governments, not our hospitals are used to use consultants, are used to use people who know the business, who knows the market, and try to do it. Yes, Estonia is very, very far away if we compare it with other countries with PPP, and that's fantastic. But I would urge everyone, just ask opinion to other people who have already done it.
That's a good tip. Anyone want to react? Yes, Jaanika?
Yes, I very strongly believe that the best products come out when we have a collaboration between the patient, healthcare professional, IT specialist, investor, and entrepreneur, not a doctor who is only just a doctor, but doctors should understand what IT is capable of. Patients should have the say in what they're expecting. Policymakers should support in regards to legislation enabling that, and that could only happen in collaboration, not in separate silos.
Michel?
A brief comment to that. I agree with you both. At the same time, and especially nowadays with this geopolitical situation that was touched upon already in the introduction of this day, I think that we have to find a good balance when it comes to these matters. And if we're talking about, for instance, critical infrastructure or sensitive data of different kinds, then we must know what kind of collaboration we have with, for instance, international or cross-border enterprise of some kind. We know, for instance, the problems right now with cloud services, and it's very much talk about, we had a GDPR conference, for instance, in Sweden earlier in the spring, and the buzzword was, do you have an exit strategy? That is to get out of such solutions, third country owned, or to be very clear, US owned, if you see that this is not complying to or may not comply to GDPR, for instance, and other risk assessments like that. We must take those aspects or perspectives into consideration as well. So it's not that easy to say that we always need to have a public-private procurement that you mentioned, for instance, or we have to weigh different alternatives against each other to find the optimal solution, or at least the least worst solution in a way.
Excellent, thank you. We still have time for the final round, so I want to go back to the title of this panel. So the European health data space, still a dream or reality? So let's start with you, Leon, and your 1 minute take, like, what is it in your perspective, a dream or reality, and what does it take us to get there?
Yeah, so maybe I'm talking about, in this perspective, the customers that I work with, the companies that make AI-enabled medical devices, they're at the end of the line, I guess. If all the other parties are not aligned and the data is not being unlocked, then they are the victim at the end of the day, I think, of not having the data available. And I think today, for them, for those organizations, it's still a dream. But I hope it to be reality soon.
Yes,
I guess that's my 2 seconds.
And Jaanika?
It's not 0 or 100. We are constantly dreaming about having it better and more. We're constantly evolving. So I would say we definitely have some bits and pieces in the place, but the perspective is so much bigger. I so much look forward to AI that will really help to prevent, predict, having this secondary data sharing smooth and easy and so on. So we're making it happen while dreaming big.
Excellent. Michel?
Well, I think it was in the morning session was Aiga who encouraged us to dream, actually, and I think she's right. And EHDS will be a dream for the next 50 or 100 years, I would say, for the European Union.
Is it like a nightmare?
Because it evolves all the time.
Is it like a nightmare kind of dream?
No, I think it's a positive dream, but at the same time, because there are such beautiful ambitions in it that we need to really take care of. But then actually I would say that it's in a way also a reality already today, because we have, for instance, other EU projects such as EUK with cancer imaging, we have the genomics digital infrastructure, we have the innovation hubs, we have TEF Health AI, for instance. And all of these in also EU consortia are contributing, actually building EHDS today, and in a way maybe forerunners. And we must learn from them, and at the same time, guys like me have to point and say, no, wait a bit. This is what the regulation says. So giving and taking. So I'll stop there.
Yeah. Andrew?
Yeah. In 2008, a European project called EPSO started working on the cross-border e-prescription. And I remember I worked in the State Agency of Medicines at the time. And the eHealth people came to us to explain the project and how the cross-border e-prescription is going to work. And I remember very clearly sitting there and thinking like, okay, maybe EU has a lot of money and somebody has to spend it, but this is never gonna work. So luckily I didn't say it out loud because my first job when I went to TEHIK, my first work assignment was actually to work with the e-prescription that had just gone live between Finland and Estonia. So I had to admit that I was wrong. And I think EHDS is the same. Like, it's going to take a long time, and it's not going to be perfect, and everyone will be like disappointed and disappointed again because things are not going as fast as we want. But it will be moving towards the right direction. So it's like preventing road accidents or something. You will never get to 0 or like 100 in case of EHDS, but every step towards the goal is a step forward.
Important.
Yeah.
Somebody, I believe, has said that if you can dream it, you can do it. So we have been able to dream it. So, and now we have to be really careful and, I don't know, tender and focused on each detail to be able to do it. But I think it's already the beginning of the dream come true. So I'm optimistic, and I hope that this dream will come true. Yes, it's maybe not 100%, it's not fully perfect, but at least the core, the essential things that we need so much at the moment, I think we can do them.
Excellent. Thank you very much for all your very valuable input. And I fully agree that we should never stop dreaming. That is the only way how we can also push forward the boundaries and also make new discoveries in science and research. So let's continue the work together. And let's give a big applause for the excellent panel. Thank you.
Thank you, Elina and the panel. Can you please stay here for just one moment? We'll take a picture with you as well. And for the rest of you, there's still coffee served and a little bit of time of networking. Will continue 4 o'clock.